we've shown with the urine before and after that if there are any bacteria before, they're gone after the installation. So we definitely know that it is potent, confirming what we've shown in the lab.
Dr. Philippe Zimmern is a professor of urology and director of the Bladder and Incontinence Treatment Center at UT Southwestern in Dallas, Texas. His expertise covers urinary incontinence, prolapse, and urinary tract infections. We previously interviewed Dr. Zimmern about bladder fulguration for chronic and recurrent UTI, so you can check out those videos for more in-depth information. Today, we're going to discuss Dr. Zimmern's recent research, which includes a look at the very long-term outcomes for fulguration for UTI, insights into bladder installation, and studies on the urogenital microbiome. Thanks for joining me again to share some updates.
Thank you, Melissa. It's a pleasure to be back with you. Can't believe it's been 3 years already.
I can't believe it either. When we had our last call and we realized that, I was very surprised it's been that long.
Yes, many people have commented about the wonderful work you are doing with your team and how useful this recording was for them. So
yeah, it's been great to have that resource. But since we spoke last, you've published many, many papers. So we put the question out to our community to submit their own questions, and we've gathered them on a couple of different topics. So I thought first we could talk about the urogenital microbiome research that you've been doing. And you recently published research that looked at how recurrent UTI and estrogen shape the composition of the post-menopausal urogenital microbiome. Can you describe the design of that study so that we have a context for the questions the community submitted?
absolutely. And for this particular topic, I'm very grateful for the team of researchers that are the key authors of that paper. I'm only a participating individual in that group, but there are some fabulous scientists and work done at UT Dallas in particular that I would like to acknowledge first. So the idea was that basically we know that vaginal lactobacilli protect the vagina against bacteria. And the question was, are these lactobacilli also having a protective role in the urine?
Mm-hmm.
So we basically studied groups of women who have had different hormone levels from systemic or vaginal source, and found some differences. The enrichment in lactobacilli was much stronger in those who had systemic hormone, and much more variable in those who had vaginal hormone exposure. And that's important because obviously we encourage women to use hormone preventively for recurrent UTI infections. So that led into a lot of questioning about, what dose, how quickly does it work, what changes does it make? We've opened a new Pandora's box.
Yeah, I don't suppose you have any of those answers yet then.
It's growing. We are building data right now. We have some grants that will provide some information as well that are almost finishing up on the microbiome. So give me maybe another year and there'll be a few more papers.
It's maybe surprising to some people that the result was that the systemic estrogen was actually more beneficial than vaginal estrogen, because most people that we've heard from have tried vaginal estrogen and have found that to be beneficial. And now you're saying the systemic estrogen might be even more beneficial in terms of a healthy urogenital microbiome.
Correct. Yeah, it's really not a complete surprise to some of us, because we always encourage people to use both if they have any issues, especially if they have vaginal atrophy or menopausal syndrome. But in terms of what really happens between the vaginal lactobacillus and the estrogen is not very well understood still. So we have an ongoing study where we're measuring the changes early on as women start to be on hormones. Almost on a weekly basis. We're expecting the NIH to fund that, but we've started the study nonetheless. So, and we just have to get the data just to figure it out.
Yeah, it's really important data to gather. Can you talk a little bit about the actual differences in the microbiome that you found between the group who were taking estrogen therapy and those who weren't?
Yeah, it's complicated because, the microbiome is, hundreds of bacteria. And there's some dominant one like the lactobacillus, but in the world of lactobacillus, you have also a lot of different, lactobacilli. So even what those different ones do and how they interact with each other is also under investigation. So I think we're going into really deep diving here, which is probably beyond what we should discuss. I don't think we first have enough strong data yet to have the discussion, but it's clearly a much more complicated world than we can imagine.
So maybe we can save that for next time then.
I think as data grows, I think we should revisit that. And I suspect that with the ongoing data that we are acquiring and the quality of the microbiome work that Dr. Dennis and our group are doing, we should get to very good data in the coming years. Yeah.
Okay, that's great to know. Well, let's talk a little bit about then how the history of recurrent UTI impacts the urogenital microbiome. What did you see in patients who do have a history of recurrent UTI versus those who didn't?
Yeah, definitely there is some memory in the system. So when you get exposed to antibiotics, you increase your risk of antibiotic resistance genes. And so that echoes the worry worldwide about, antibiotic resistance and how it's not benign to take an antibiotics. And that's going to, connect with another topic we will discuss today, which is how do you treat women when they have an infection? You get culture-based, so you just empirically treat them. So I think it's a great segue to go into that discussion. But definitely you cannot say that there's no memory. Your body remembers when you've been exposed to antibiotics.
Well, there's one more question before we switch topics, which you also might not be able to answer. But is there any long-term benefit from the estrogen therapy? Does it shift your microbiome permanently, or do you only have the benefit while you're using the therapy?
That's a question nobody has explored because typically when you start, you stay on it. That's a recommendation. So I don't think I have anybody in whom I have data of what happened after the stop. So my suspicion is that it takes such a fairly long time for the microbiome to change while you're on hormone. It's not happening immediately. That I would not encourage people to stop once they start. But the question you're asking is that if you do it for, let's say, a couple of years, are you going to be dealing with a new microbiome because you've been exposed to that for a couple of years? I don't think we know the answer to that question.
Okay.
But my hint is that you should stop. I think the moment you stop, you will probably revert to the way you were before you started.
Okay. Interesting. And you just mentioned the other study we want to talk about, which is the treatment based on culture versus empiric treatment.
This was really dear to me during COVID, where women could not get to a lab for culture. We had to treat them based on symptoms. Obviously, we were, in quote, violating the guidelines, which is always to have a culture to guide therapy. That's what our guidelines say. And here we were faced with, no resources. So we studied that and we published a paper at that time on that experience. That was a very pragmatic situation where, for safety reason, we chose to abide by the guidelines when women called earlier in the week, because we knew that, it was not a weekend. They could call us if they had fever, if they had any worsening of their symptoms. We felt that we could monitor them and wait until the culture came back, which is a big issue of, being with days of suffering while you're waiting for that culture to come back. Whereas if people call at the end of the week, they were pretty much based on empiric treatment. The study we have right now is randomized, regardless of when they call in the week. And, that's obviously a study that we started to do because we realized that empiric treatment was not inferior to culture-based. And I think intuitively, all of us think that, the longer you leave this bacteria to grow in the bladder, the more potential harm they can make. So an early treatment would make sense. The problem is that we don't have any good ways to figure out what happens early on at the moment. So I think, we would love to have a system that allows us to figure out in a few hours which bacteria and what antibiotics we can give to people. We are not there yet, unfortunately, as far as the technology that we have available. So we still have this dilemma. Do we wait? Abiding by the guidelines, don't expose people to antibiotics that may not be helpful to them, or we just jump in with what we use as first-line treatments, whether it's natural furantoin or sulfa drug, whatever the person can take based on their prior history and allergies. That's a daily challenge. I know that many people have switched gradually to more and more empiric treatment, but our infectious disease colleagues are not really pleased with that because they're very worried about the resistance building up worldwide. And I totally understand the challenge. In fact, that we submitted this as a grant and it was turned down because of that, because the grant was not following the current guidelines, even though it's real life practice.
And it could be relevant for those patients who have a urine culture that comes back negative, even though they have UTI symptoms. And we know that standard urine culture is not 100% accurate. So do you think in those situations, this method could apply, that empiric treatment should be used, even if culture is not helpful?
That's a great question, and I don't know the answer to that one. It's probably the worst scenario where people have symptoms and nothing grows. I tend to repeat the culture if that's the situation, and I definitely look at the urine analysis to see if there's clearly signs of infections with white cells, nitrites. So, it's not just the culture in that situation. It's obviously more, a larger view of the situation than just the culture result. But that's a very tricky one.
It doesn't
The next
seem.
generation sequencing is not terribly helpful because it picks up anything in the urine, good or bad. And we know that women who never have infection and have bacteria in the urine. So that's not been very helpful to us. That group of women, Alyssa, I don't know what the right answer is right now. But for those who have symptoms and the culture that's going to grow, we've figured out that, about 10% of them, we had to switch to different antibiotics. We had people with resistance. And it happens more obviously in women who have recurrent UTI. So they know their symptoms well. They're anxious about having a few days of misery waiting for the culture. They're insistent that we treat them. And I totally, feel for them. I think these scientific knowledge is not there yet to tell you which way to go, unfortunately. So I think the hope is that we can find technology that will shorten that, waiting time of 2 or 3 days, depending where you are. And some can handle this 2 or 3 days fairly well with, fluids and D-manos and whatever else they want to take, AZO, Puridium, whatever. But some are in the bathroom every 5-10 minutes, and it's so painful that they cannot tolerate that. And I get it.
Yeah, we hear from a lot of people in the community in that kind of situation who don't get positive culture results, or even if they do, the treatment is just not working well enough for them. But that's kind of why we're talking
That's
today.
another issue. Of those who get the treatment, some are not responding.
Yeah.
That's another different topic where we wonder if we've missed a bacteria that didn't grow or the dose that we give them is not sufficient. We don't have ways to measure antibody concentration in the urine rapidly either to know if we're effective. So, we're treating people with a limited amount of knowledge right now.
I think patients feel that, and that's why we get so many questions about the different treatment approaches. And one of those that comes up quite often are bladder installations. So a lot of people either just feel like they can't take more oral antibiotics or they have concerns about doing that because of gut health. You've done a lot of research into this, and a recent paper of yours discussed a type of bladder installation. Can you first share some logistics about how treatment is delivered directly into the bladder in this way?
Yes, so obviously, if you have limitation in oral antibiotics because of allergy resistance, side effects from taking these antibiotics, a logical thought is, can you place it straight into the bladder? And this is not a new thought. This has been done for a long time, but it's been done mostly in women who have a catheter permanently because they can instill something through the catheter, or those who do intermittent catheterization. For those who don't do that, the idea of inserting something in the bladder is not very appealing, first. And second, you definitely don't want to do that when they have a raging infection, for sure. So the problem with this approach is more in between acute episodes. What can you do to try to make sure there's no leftover infection in the bladder? Is there anything that you can deliver inside the bladder that would help? So a few years ago, we did a review of the literature, and to be frank, it was a bit disappointing. There were not a lot of options. The two main ones were gentamicin on one end, the aminoglycosides, and others have been used, not just gentamicin, but that's the one that's used the most. And then hyaluronic acid, which is not available in the US, available in Europe. And both of those are delivered with different, concentration of those, which we can talk about, but this is just like, cooking recipe. Some person use this, some person use that. And the frequency of installation was highly variable. Some had weekly, 6 weeks, some had daily for 2 weeks. I mean, just name it. It's just
Yeah.
so the rationale is very limited. So for gentamicin, the problem is, as you probably know, it's a large molecule and it doesn't penetrate the biofilm on the surface where the bacteria hide. And so I think it's good for the floating bacteria, but it's obviously not fixing deep-seated bacteria and infection like we have demonstrated in the past. So until we have a way to affect the biofilm, which I don't think we really know how to do that well yet, this is going to be a limited, approach for patients. But it's an exciting field of investigation. I know there have been some efforts with phage therapy, which used to be very popular before the era of antibiotics in the 1940s and 50s. And some people have tried to resurrect that same idea, trying to place something in water that will affect the bacteria and kill them. We have worked on a new intravesical agent. I can talk maybe a little bit about that now if you're interested.
Yeah, it'd be great to hear about that. One question that you just touched on was the infiltrating a biofilm. Is it possible to put a biofilm disruptor of some kind in an installation? And if so, what type of compound would that be?
I'm not aware of any right now that has been scientifically proven. I heard people are taking different herbals, different ingredients. Maybe you know some, I don't know. But I don't think I've read is solid scientifically, proven with shows, basic science lab work, animal studies, human studies that have shown that we can disrupt the biofilm. Bacteria have been there for millions of years. They really know how to protect themselves.
Yeah.
Not sure we're there yet. So obviously that would be great if we could.
It would be. We also haven't seen any papers that really show that that works. There's people, I think, working on it though. So hopefully we'll have more information soon.
Totally. I think this is a fabulous area of research. I mean, anybody that works in the field of biofilm and bacteria is dreaming to be able to figure this one out. So I think it will happen. I don't think it's there yet.
Yeah, it doesn't seem that way, but we're always on the lookout for that research when it is published. You recently looked at a different type of installation. Can you describe what that installation is?
Yes, I was blessed in a way to have a discussion with a pharmacist who I was reaching out to him about gallium, which has been attempted also for treatment of infection, but gallium is really hard to provide in the medical grade shape so that you can instill it in patients. So during our discussion, I said, I've been using that cetylpyridine chloride, and it's been used for other applications in the body for mouthwash, ear, nose, and different things. So it's a very safe product, and I've been testing it in my lab, and I know it's working on bacterial, uropathogen bacteria. So he encouraged me to look into that. So I turned to my colleague at UT Dallas, Dr. Denisco, so to do some work on that, cetylpyridine chloride, CPC. And sure enough, it binds to the membrane of bacteria, which is negatively charged, and basically disrupt their integrity. And so it leads to bacterial cell death very quickly. Not all bacteria, some are extremely resistant, like Pseudomonas, but that's not a very common one, fortunately, or Proteus. But the most common one that we see, it's a very powerful agent. So we've started to, at the time, initially I petitioned the FDA to get permission to use it in the women who were having really severe infection and were considering a bladder removal at that time. So they were ready to have something placed in their bladder. And that worked pretty well for 2 of them. So it was really impressive. Then after that, we got a permission at the university here to do what's called an off-label study where we would install it in our patient in the office. And we're currently finishing up a publication looking at safety. So I can tell you it was safe. looking at resistance. They don't see any resistance build up with it. So we're building some core information about that. I'm not offering it to everybody. I'm very selective who, we offer it to. Those are usually women that have had repeated fulguration and continue to get infection.
Right.
Sometimes I can't see anything wrong in their bladder visually. They can cauterize, but I know there are bacteria there because they keep getting infected.
Yeah.
So we've used different regimen of instillation, and we're adjusting, tweaking things, and hopefully submitting a grant later this year or next year on that based on this data. So
interesting.
Stay put. It's
do you think
again, something that requires both, science, basic science, and clinical data to, and obviously, once the safety part has been assessed, I think we're good. People don't have, a lot of pain afterward. They can tolerate it well in the office setting. They don't end up in the emergency room, or have
very important.
Anything major. So, the safety is good. We've shown with the urine before and after that if there are any bacteria before, they're gone after the installation. So we definitely know that it is potent, confirming what we've shown in the lab. But in terms of, how many times we have to give it, what's the best regimen? It reminds me of the days where we were trying BCG for bladder cancer, and we were trying to figure out what was the best regimen. And so that's going to be a process.
It sounds complicated. Do you think in general installations are something that patients can do themselves at home, or is it always best done at a clinic?
We can teach people to do that. They will be the next step.
Okay.
But right now it's done in a clinic setting because we have to still assess people scientifically. We need to get urine before, after. We have to make sure they're doing well. We have to see the effect in their bladder with repeat cystoscopy, so we can see, that indeed there's no visual changes. So, I still have a scientific mind behind that approach. You're looking at 5-10 years from now, if it does work, yes, of course, you would not want people to have to come to your office and just do it at home. And so
that was one of the questions. If this is effective, how long do you think it will be until it's available to patients?
It is available right now. It's just, I don't think we have the science to guide people on how to use it. So it's the compound exists, and it's not like something that only a few people can use. It's readily available.
Yeah.
It's just we don't know enough to know how to provide it and be efficient for a given person. So but it's a big area of work for us. We're trying to push grants to figure this out. So
yeah, well,
it's definitely more powerful to me than anything else I've used so far. So I'm very excited about it.
It sounds really interesting. If you do go ahead with a trial, you should let us know so that we can share that information with people who might be eligible. Thanks so much for watching. I hope you found this expert video helpful. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. We'll drop some links in the video description. If you like what we're doing on this channel, you can support our work by hitting subscribe here on YouTube, and don't forget to tick the bell so you'll be notified of our future videos. Thanks again for watching, and until next time, keep asking questions and pushing for better solutions.